Office tools for better decision making. As defenders of the detrusor, we need to know how to best use our urodynamic shields. And so the era of uroflowmetry from home has now come of age. It's giving us the power, the statistical power to generate a lot of data. I mean, look at this. 486 patients were able to generate 20,000 home uroflows, and we're learning a lot. A quarter of abnormal office uroflows are actually normal when they're done at home. And then 30 voids is needed to be within about 10% of the true value for Qmax. Audio Uroflow is going to take this to the next level. How awesome is it that we can just put a smartphone on the toilet and we can actually listen to our urine flow and get data? Is it perfect? No, there's a lot of shortcomings, but we are now able to enter an age where we can revisit academic assumptions because now we have better data from home. We compensate for intrapatient voiding variability, and we can ask questions like, hey, is there a better Qmax cutoff to predict bladder outlet obstruction? Ultrasound needs to assert itself as the leader in the category of basic urodynamics. It is progressing very quickly. Here's a quick point of care ultrasound showing my bladder, but soon we will have 3D reconstructions of the bladder and the prostate for pre-surgical planning. Bladder ultrasound is the critical player and leader within basic urodynamics because it tells us directly information about bladder health. Recognize across the world there are many different methods, but we all share the same mission, which is to save more bladders. Find what works for you, whether it's bladder weight, bladder wall thickness, or detrusor wall thickness, which is what the tribe ascribes to. It's used all around the world, even here in Nepal. Suprapubically, at least 250 cc's in the bladder. Enlarge the images to about 8-fold, and it has good predictive value and sensitivity. We like it because, yes, it is a direct measurement of that detrusor under duress. And within the category of basic urodynamics, it is our go-to. We should be doing more of these. And it makes sense pathologically as we have hypertrophy with deposition of extracellular matrix. We understand that it's much more complex than that. But at this time, it's being used well in many parts of the country, like in Egypt, where they found you can diagnose and quantify with an accuracy approaching standard pressure flow studies. And in Germany, it was given a grade B for evidence in their 2023 guidelines. Defender Magistro even states, look, we're going to start doing more of these ultrasound-based techniques because it is considered a basic diagnostic step, right? We've put it in the category of basic urodynamics because it is a good parameter to suggest outlet obstruction. The enhanced urodynamic category, looking at one of them, penile cuff test. It's a blood pressure cuff on the end of the penis and inflates during voiding to stop urinary flow. At the point where it obstructs flow, that pressure is the isovolumetric bladder pressure, and it is a measure of bladder contractility. It's not as good as advanced multi-channel with a sensitivity 80%, but when combined with a Qmax, we can now create a 4-quadrant nomogram. Green is good or unobstructed, red is bad or obstructed, X is the patient. The x-axis is increasing maximum flow rates. The y-axis is increasing bladder pressure. How hard is the bladder having to work? So as that prostate gets bigger, the donut hole gets tighter, and we start to see the flow start to decrease as the pressures rise in the compensatory phase, eventually reaching a point where it reaches a breaking point, after which the bladder begins to fail, and you have decreasing pressures and flow. It is never going to be as good as multi-channel advanced urodynamics. It has other limited availability as well. Cystoscopy. I want to return to this because for advanced urodynamics, this is the backbone of so many levels of diagnostics. And we can see here, when do we do it? Well, we do it when a bladder is at risk based on the triangle of triage. And why we do it is because it tells us that detrusor is under duress. I recognize this is controversial in the recent past, but I want us to trust our expertise, our experience, trust the truth of trabeculations. We know what a bladder looks like when it's under duress. Plus, we're getting so much more information about other pathologies to explain the complexity of the male LUTS landscape, and we're getting information not only about the bladder health, but also the prostate shape, which we can learn from good cystoscopy. More important than new diagnostic tools is this new diagnostic approach where we are bladder-centric. Meet Leo. He's a 72-year-old, came in for a second opinion for urgent incontinence. Sex matters to him. Ejaculation matters. He was a victim of the polypharmacy epidemic. With the proper bladder health counseling about the amazingly unique non-transplantable bladder, educating about the 5 stages of bladder health, he knows that his bladder health matters to him because he is already in stage 3, and we all agree we do not want him to get to stage 4 and 5. He's highly motivated to figure out what he needs to do to stop the progression. With his 68-gram prostate, he meets 2 criteria by which this triggers a bladder health baseline. Specifically, the standard level is a combination of basic and cystoscopy. And we see that here where the standard level, once again, coupling basic and cystoscopy in the advanced category. We're now completing the trifecta. We're seeing detrusor function, diverticulum, trabeculations. We now have a sense of the shape, high bladder neck, circumferential obstruction, and we already have the 68-gram prostate. This is a bladder at risk for damage and dysfunction. I'm very lucky that I can offer my patients elevated level of diagnostics by adding enhanced penile cuff. He is still obstructed. This is still a bladder. I just happen to have a little bit more data. Something still needs to be done for this bladder. The standard level is the minimum that defenders provide. Looking at the elements of good health policy, no matter what stage a bladder is in or stage is, the bladder is always going to advocate and vote for maximal deobstruction. But it recognizes it must compromise with shared decision-making. The patient has a very strong voice. He wants to preserve his ejaculation. I want the best treatment, the most effective, the most durable, and we have a healthcare system that allows us to do either fractional or maximal, so we elected to proceed with the least invasive surgical therapy. Happy patient, happy bladder, happy life. We're able to reduce his symptom score within a couple months down to 5. Bladder was stunned. And then over a year, we see that the bladder recovery is seen. He's no longer having urgent incontinence, IPSS of 2. He's no longer obstructed. He's now in quadrant 2. And he's no longer in stage 3. In fact, he's not even in stage 2 or 1. Defender Al-Saudi from Sweden asked us, hey, is it a one-way ticket when we have BPO and it progresses to dysfunction and damage? And Defender Alverbeck with us today asked, is it possible to actually reverse it? And the answer is, it is a two-way ticket. We can stop progression. We can reverse it if we deobstruct at the right time within the window of curability. Academic leaders have asked us to challenge conventional wisdom. So I looked at the guidelines in common practices around the world and found that there are many areas of improvement that we need to strengthen if we are to be prepared for the tsunami of LUTs. The Man vs. Prostate Manifesto coming out in the winter outlines many of the optimizations we talked about today to address our shortcomings and to help us realize the vision of all of our patients living their best lives, chemical-free and catheter-free. And it starts with cherishing, celebrating, and prioritizing the preservation of bladder health for a very unique organ that's not even transplantable. So please lean into your responsibilities to protect the bladder. Be the defenders of the detrusor that we are. Join the dialogue on LinkedIn and manvsprostate.com. Choose data over drugs. Deobstruct the right prostate at the right time within the window of curability. Let us go save more bladders. With that, this ends the part 3. Thank you all for all your contributions, your insights, expertise, and experience that has helped really guide a lot of these thoughts. And together we can make a positive change. See you on the next one. All right, bye.